No, ma'am.
Okay, no questions. So then I introduce the next speaker. That is Dr. Anupama Gill Sharma. She is Associate Professor at ABVIMS and RML Hospital. Her area of interest is critical care, difficult airway management, regional blocks, and transplant anesthesia. Over to you, Dr. Anupama.
Good afternoon, everyone. The topic for my talk today is fiber optic intubation. This is a very important topic which can be asked both in the theory as well as in the practical. So to begin with, let's go about something about the history. The first transmission of visual image was first reported in 1954. There was an English anesthetist, Peter Murphy. He used a fiber optic bronchoscope to aid in the nasal intubation. Since then, many advancements in the technology of fiber optic has occurred. And in 1972, the first series of 100 fiber optic endotracheal intubations, both nasally and orally, were reported. Little bit about the fiber optic technology. The fiber optic bundles, fibers are very thin, small, glass fibers of around 8 to 25 microns, which are insulated by a fiber glass layer of a different optical density. So it's an organized coherent bundle of fibers which runs through the entire length of the insertion cord. It has the same orientation on both the ends. So there's a separate fiber optic bundle which is attached to the light source, which provides illumination. So there is a fiber optic bundle throughout the insertion cord, and also there is a fiber optic bundle which connects the light source which is connected to the light source to provide the illumination. Now going on to the components of the fiber optic scope. So there's an eyepiece. Yeah, I'll show you in the diagram here. So here it is the eyepiece through which one looks into the scope. There's a diopter ring which is there for focusing. There'll be another focus if you attach it to the camera. There can be a camera focus also. This is the control lever. Here is the control lever through which the tip of the fiber optic scope is moved up and down. I'll also show you later. Then there is a working channel or the working port through which the suction can be applied. The drugs can be instilled like in a spray as you go technique if you want to instill the local anesthetic. Also, the various drugs can be given through it. Oxygen also can be given through this port. And this whole component here is the body of the fiber optic scope, which consists of all the components including the eyepiece, the focusing ring, the working channel, and the suction. Here, this is the insertion cord, which is around 60 centimeters in length. Here is where the light source is attached. And then there is a suction port also. Suction valve and suction port. Pressing it will cause the suction to occur. So here again, you can see here is the lever, which can be moved up and down to facilitate the movement of the tip. The eyepiece, the focus, and the working channel, and the light source. And here is the suction button. The tip of the fiber optic scope typically has a working channel. This is the working channel through which drugs, oxygen, suction can be done. These two are the ports which contain the angulation wires which can control the tip movement of the tip of the fiber optic. Up and down. These are two movements possible, up and down. And here is the channel which has the cladded fiber optic lighted bundle. So there's one bundle for transmission and there's a bundle for illumination, also light illumination. Just to mention that nowadays various other video bronchoscopes have come. The difference between these two are, this is not based on a fiber optic technology. Here the image is there is a lens which is there at the tip of the video scope, and through which there is a camera chip which is there, which converts it into a digital signal, and that digital signal is again processed by the digital processor and it is converted back into an image. So this does not run on a fiber optic technology. Disadvantages are it is much more cheaper, and this disinfection, decontamination is easier, but the image quality is poor, and the more lasting time tested is a fiber optic scope. But disadvantages of a fiber optic, and it's a very expensive equipment, and disinfection is a tedious process. Sterilization has to be thorough, because there can be chances of cross contamination if it is used between the patients and not sterilized properly. Also, there are the cost of damage repair is quite high. So I'll be focusing only on the fiber optic scope today. So few indications of awake fiber optic intubation are an anticipated difficult airway, like in a TMJ ankylosis or a contraction neck bone contracture. Typically, if the mouth opening is less than 1 finger. If there's a history of a difficult intubation, mouth opening is limited, unstable cervical spine, we do not want any movement at the cervical level. Abnormal anatomy of the airway, hidden neck cancer, there's a trauma to face and neck, or so in all these are possible indications of awake fiber optic. Or even for indications for a fiber optic as such can also be to look at the position of the tube. If you're putting a DLT, you have to confirm which side the tube has passed. The various options are one can perform an awake fiber optic intubation, and it can be done under anesthesia, anesthetized and paralyzed patient if the mask ventilation is not a problem. And there are two routes by which it can be performed, that is oral and nasal. So I'll be focusing specifically on the awake fiber optic intubation method. Very important is about the awake fiber optic intubation. There are 4 components. There should be a psychological preparation of the patient, and in the psychological preparation, it is very important that you have to ensure that the patient is well informed about why he has to undergo an awake tracheal intubation. So a walkthrough of your technique, and like what all local anesthetic drugs you are going to give, and the fact that it can also taste unpleasant, your local anesthetic. Also, that he can have a coughing, he can have a hoarseness of voice. These all possibilities should be explained to the patient. Again, using of the airways, which that he might feel airway in his teeth, that also has to be explained. You should also tell him that at all the times he'll be safe. There'll be an alternative plan if the awake fiber optic intubation fails, and oxygenation will be maintained throughout the period, and there'll be help just in case there's a failure of the procedure. And it is very important, particularly if he has to come back for future procedures, because a bad experience would stay in his mind, and it can be very traumatizing for the patient. So a good psychological preparation of the patient, taking his consent, is of utmost importance. Then is the anti-salagogue. Anti-salagogues are typically used if there's no contraindication. So it will decrease the mucus production, and it will also decrease the secretions, and would give a good field of vision. Typically, we are using here is glycopyrrolate 0.1 to 0.2 milligram can be used half an hour before intramuscular, or even IV before the procedure. Other options are atropine and scopolamine. Then there is a pre-medication, and then airway preparation. An ideal sedative technique is the one which gives a good anxiolysis to the patient. He has amnesia, analgesia, the suppression of the gag and the cough reflexes. It is easily titrable with minimal respiratory side effects and rapidly reversible. Typically that we are using is fentanyl and midazolam with a small boluses of around 0.5 to 1 milligram of midazolam. Fentanyl may be in boluses of 20-25 micrograms. Propofol, if given in a titrating doses and sedation and puncture sedation doses, can be of very good help. Nowadays, dexamethasone is extremely popular. It is an alpha-2 agonist. It has good analgesic properties and sedative properties without causing respiratory depression. About 0.2 to 0.7 micrograms per kg per hour infusion can be started, and many studies have been done for it. It is an excellent drug of choice if used appropriately. Other combinations can be ramifentanil is a short-acting opioid, and with small boluses of midazolam can also be used. So, advantages of giving a sedation is that it will allay the patient's anxiety and discomfort, and increases procedural tolerance, and there is amnesia. Disadvantages are there can always be a risk of respiratory depression and losing the airway. There can be hypoxemia if the patient goes into a deep sedation. There can be hemodynamic instability. There can be risk of aspiration. So our idea here is to, when you are giving a sedation is, it can be achieved, awake intubation can be achieved with or without sedation, both. But if the sedation is used, the aim is for minimal sedation. So it does not affect the patient's breathing or the hemodynamic compromise. And he maintains the ability to speak or respond to your verbal instructions. And yet he should not be deep enough. He should be deep enough to be relaxed. So having a second anesthetist who can run the sedation, monitor the patient for you for respiratory depression and hemodynamic compromise is the safest approach. And if you're not an expert, use a single agent rather than a combination. Now going on to the airway local anesthetics used in airway anesthesia. So this is just to give you a brief about the sensory innervation of the airway. The trigeminal nerve, glossopharyngeal nerve and the vagus nerves are the ones which supply the airway. The trigeminal nerve supplies the nasal and the nasopharynx, glossopharyngeal in the oropharynx and the oral cavity, and the vagus nerves in the periglottic, supraglottic and infraglottic structures. So the vagus nerve, the two branches, superiorlaryngeal branch, superiorlaryngeal nerve supplies the supraglottic area, sensory supply to the supraglottic area, and the recurrent nerve is the one which supplies below the vocal cords, and glossopharyngeal nerve supplies the base of the tongue and the valvula. So glossopharyngeal nerve itself alone blocking will not aid in a successful awake intubation, but it will be very helpful to abolish the gag reflex. So the three blocks that we give are supralaryngeal nerve block, glossopharyngeal nerve, and the transtracheal translaryngeal nerve block. So topical anesthesia, superiorlaryngeal nerve block, translaryngeal block, and glossopharyngeal block. These are the topical agents that we use typically. So the patient can be anesthetized, can be given a nebulization with a 4% xylocaine solution. So the advantage is it can reach into the deeper airways, into the trachea with a good effective nebulization if it is done. The disadvantage is it is time consuming. At least 15 to 20 minutes to half an hour is required, and is also dependent upon patient's cooperation, how well he inhales the fumes. Then there is a xylocaine 10% spray which can be sprayed directly into the nasal cavity. You can ask the patient to stick out his tongue and it can be sprayed over the oropharynx and the nasopharynx, and even deep down above the vocal cords if the mouth opening is not an issue. Then lignocaine jelly can be applied with the spatula on the tongue and the oropharynx, and it can also be used in the nasal cavity where nasal intubation is planned for lubrication and for anesthesia. Topical solution of xylocaine can be used, and viscous gargles also the patient can be asked to use. The typical ways of anesthesia of the airway can be done with local anesthetic soaked in the ribbon gauze. Like this, it can be put in both the nostrils. Patient can be asked to breathe through the mouth and leave it there for a few minutes. If otherwise, cotton applicators or McKenzie technique or mucosal atomization device which has a pre-filled syringe with an accurate dosing, has a malleable stillet to deposit the local anesthetic into the particular site can be used. or inhalation of nebulized lignocaine, as I told you, or spray as you go technique is the one in which the epidural catheter is passed through the working channel of the fibreoptic scope, and it can be directly, the local anesthetic can be directly instilled over the vocal cords as you see them. Role of vasoconstrictors is very important. It can shrink the nasal mucosa and increase the size of the nasal airway passages. So coming on to the blocks, glossopharyngeal nerve block is done by asking the patient to stick out his tongue. The tongue is displaced naturally with the tongue blade. Place a 9 centimeter needle, about 22 gauge needle, and at the inferior portion of the posterior palatopharyngeal fold, that is just behind the tonsillar pillar, just a little bit deep into the mucosa. 1 to 2 ml of local anesthetic, 1% lignocaine can be used. So here how it is shown is palatoglossal arch and palatopharyngeal arch, so behind the tonsillar fossa. Supralaryngeal nerve is blocked at the just below the greater corner of the hyoid bone. A 25 gauge needle can be used. The bone is pressed towards the side which is to be blocked, and a small needle just inferior to the greater corner of the hyoid bone and superior to the thyroid cartilage can be used. Is a landmark. About 2 to 3 ml of local anesthetic around 0.5 to 1 centimeter deep to the skin. 1% lignocaine can be used. This will be, and repeat the procedure on the other side. Translaryngeal nerve block is very, very effective and very useful if done properly. It will help a lot in anesthetizing the infraglottic part of the airway. So here they have to identify the tricothyroid membrane between the tricod and the thyroid cartilage. Place your thumb and index finger over the membrane. Use a small 22 gauge needle. Pierce through the tricothyroid membrane. Goes right into the trachea, and always aspirate for the air so that you are sure that you are into the trachea, and rapidly inject 3 to 5 ml of local anesthetic and withdraw the needle. 1 to 2% of lignocaine can be used. The patient would immediately cough up, and that will spread. That means it is rightly into the trachea, and the local anesthetic has gone up and down the larynx and the trachea. This is to show how the spray as you go technique. You can see through the working channel of the fibreoptic scope, the epidural catheter has been passed. The tip is just can be advanced through the tip of the fibreoptic scope, and it can. So the fibreoptic scope can be kept just above the vocal cords, and the lignocaine can be sprayed onto the periglottic structures. So typically we use about 1 ml of 2% lignocaine with 9 ml of saline, and it is injected. So we keep the syringes and quickly inject it with force as we see the glottic structures. This is to show the endoscopic mask which can be used. You can see there is a channel over here through which the oxygen can be also instilled, and through this particular port the fiber optic can be used. These are the various bite blocks which come, which one is planning for an oral fiber optic intubation. This is an Olympus bite block which has a larger diameter. It can accommodate various sizes of endotracheal tube. Advantages that it is of short length and it can be tolerated in an awake patient. This is a very good oral airway, ovasapien airway. It has a flat lingual portion which keeps it in the midline, and so one does not get lost in the side structures while intubating through a oral route. About 8.5 millimeters of endotracheal tube can be used to them, and it can be opened wide so that to disengage it from the endotracheal tube. This is the Williams airway. It comes in two sizes of 9 and 10 centimeter. It can also accommodate about 8 size endotracheal tube of about 8 millimeter internal diameter. Requires removal of the connector of the endotracheal tube so that the tube can be passed through it. Disadvantage is if it is not, usually it does not line very well with the glottis. Maneuvering the bronchoscope through the airway becomes difficult. This is to show that how one should angulate the tip of the fiber optic scope. If one is attempting through the oral route, it should be around 35 to 40 degree anterior, so that the operator doesn't get lost into the to the side areas in the oral cavity. One is not using the oral. One does not have an oral airway. And this is for an anesthetized patient. Maintain oxygenation is at most important at all the times. It cannot be emphasized much. One can use nasal prongs. Can use up to 10 liters per minute. So it maintains a kind of CPAP also through the apneic period. So it gives you a safety, long safety time to which you are trying to secure the airway. So this is a HFN, that is high flow nasal cannula. Nasal cannula can be used to deliver oxygen from about 25 liters per minute to 60 liters per minute in FiO2 of 1. So the apnea period can be prolonged as much as 10 minutes to the apneic insufflation, even for the apneic insufflation. And here it is shown that even through an NIV mask, the fiber optic scope is being introduced. So trying to maintain the oxygenation with the NIV. So if nothing is available, at least nasal prongs everybody has should always be used in the, if it is through the nasal intubation, on the other nasal port, if it is oral, and both the nasal ports. So the key to a successful intubation, awake intubation, is prepare the patient well, good pharmacological preparation, good sedation, narcotics only when the pain is present or has indicated. Anti-Salagog should be used unless contraindicated. Always use an emergency airway cart ready. Monitor the patient for pulse, blood pressure, ECG, saturation, and EtCO2. Always they should be an IV line. Each member has to be allocated his role clearly. Attach monitors before giving any drug. So IV sedation, no sedation for patients who have severely compromised airway. Conscious sedation for most of the patients. Topical anesthesia for oral intubation and nasal intubation. Monitor the oxygenation. A trained anesthetist is very helpful in a difficult situation. And a functional fiber optic scope and supplies. So this is to show how the operator or the anesthetist should preferably be standing at the head end of the patient, and he should adjust the height of the table so that the bronchoscope insertion cord is held upright. A sitting patient is also preferred, especially in obese patients who have got a high chances of aspiration. Sometimes patient compliance is also better. Head should be kept in the neutral position, and you should follow the black line where you are going on the airway, and that is how you advance your insertion cord of the fiber optic. The various maneuvers to open the airway, if one gets stuck while advancing the endotracheal tube, is you can extend the head, keeping the mouth closed. We'll move the epiglottis away from the posterior pharyngeal wall. So jaw thrust is very important, especially if one is attempting through a oral route. So that will open up from the oral airway. It will open up the airway. Pull out the tongue. Tongue can be pulled out with the help of a gauze or a Mengel's forceps. It increases the pharyngeal space by elevation of the tongue and moving the epiglottis away from the posterior pharyngeal wall. Once the vocal cords are visualized, maintain it in the center. The tip of the fiber optic can sometimes end up in the anterior commissural or the anterior laryngeal wall. So pull the fiber optic back a little, flex the tip posteriorly. So again, the vocal cord and the tracheal lumen will come back into the view. Hold the fiber optic stationary while your second operator advances the endotracheal tube into the trachea. Endotracheal tube is kept 3 to 4 centimeters above carina under direct fiber optic visualization, and then only withdraw your fiber optic. So this is a repetition. Nasal pass, how to anesthetize the nasal passages and the oropharynx. For larynx and the trachea, Sego technique, aerosol through nebulization, transoral sprays, and supralaryngeal and translaryngeal nerve block. This is to show how a patient is being prepared for a awake fiber optic intubation. So this is a nebulization. 10% xylocaine spray is being used, and vasoconstrictors are being instilled into the nasal cavity so as to minimize bleeding and increase the size for the passage of the tube. You can also see that oxygenation is also being maintained through the other nostril. Serial dilatation of the nasal passage is also a very good technique. If one doesn't have nasal passages, a small finger of your finger can also be used sometimes. Serial dilatation of the nasal passages with the progressive larger size soft nasal airway coated with 2% xylocaine jelly. This is a translaryngeal nerve block being given. And after insertion of the fiber optic, this is typically the view that one sees. So after you can maneuver the fiber optic up and down, and that is how the vocal cords can be viewed and the intubation can be done. Contraindications to an awake to a fiber optic intubation can be most important is a refusal or the uncooperative patient. There is other factors. If there's severe acute airway obstruction, where they can so in those patients we can go for a surgical access. Rather, gross distorted airway anatomy, where the chances of losing the airway and bleeding are high. So if the bleeding occurs, the visualization of the structures is impossible, is very difficult with the fiber optic. Raise intracranial pressure, intraocular pressure, which can increase by coughing during the awake intubation. Trauma to the basilar skull fractures, coagulopathy, allergy to the local anesthetic, and also lack of skill on the part of the anesthetist. There can be many complications like hypoxemia. So if we are not careful about the depth of sedation that one is providing, then hypoxemia can occur, saturation can drop to less than 90. Atrial fibrillation, because vagal stimulation can occur when you're stretching near the airway structures. Bronchial edema by repetitive handling of the airway. Minute bleeding can occur. Excessive bleeding can also occur if there are friable tissues in the airway. Stridor, pneumothorax, hematoma, infections, mediastinitis can occur, fracture of the bronchoscope. Then we go to what are the various problems that one encounter on using the bronchoscope. So endotracheal tube can impinge on the epiglottis. This is typically more seen when one attempts through the nasal fiber optic intubation. It can lodge into the piriform fossa. Orientation of the edge bevel is very important. So once the tube is introduced, the bevel is towards the left side, and so the tip of the endotracheal tube gets obstructed against the right arytenoid cartilage. So rotation of the tube anti-clockwise 90 degree can solve this problem. And advancing the endotracheal tube, while it asks the patient to take deep breaths about 2 to 3 times, can help to advance the tube. Match the size of the tube with the fiber optic. So minimize the play between the two so that the tube is nicely passed over. Endotracheal tube can be made more pliable, keeping it in warm water. Spiral, reinforced tube are more or less likely to be impeded. Laryngospasm, if it is there, additional topical anesthesia can be given. So these are the areas at which the tube can get obstructed. So narrowed nasal passages like in deviated nasal septum, hypertrophic turbinates, enlarged tongue, epiglottis, arytenoid cartilage, piriform fossa, and it can go into the esophagus. It can also get device a procedure factor that can get the fiber optic tip can get enlarged in the Murphy's eye of the tracheal tube. Tricot pressure can, if it is being given, can also hamper in advancement of the tube. Jaw thrusting, sometimes releasing the jaw thrust can help advance the tube. Airway intubator can be a problem, passing the tube through the airway intubator. So these are the various troubleshooting which I want to show. So here you can see the fiber optic tip has been caught up in the Murphy's eye of the endotracheal tube. Here you can see that. So once the fiber optic scope is, the tube has been preformed, bent, tube is advanced over the fiber optic scope. The bevel is typically on the left side. So once one tries to advance the tube, if the tip of the fiber optic is inside the trachea, but when you advance the tube, it gets blocked into the right arytenoid cartilage. Here rotation of the tube by 90 degrees. So you can see. So this is how a tube is how it looks like when the tube is advanced normally. So if you rotate the fiber optic, if you rotate the endotracheal tube by 90 degree clockwise, so here the bevel of the tube is in front, is anterior. So here also still it can get impinged into the posterior to the arytenoid cartilage. Here you can see that the tube, the tube bevel has been rotated 90 degrees anti-clockwise. This is the most perfect position in which the alignment of the scope with the endotracheal tube is. So the chances of successful advancement of the tube into the trachea is better. So a 90 degree anti-clockwise rotation should be done. If you do a 180 degree rotation again, it can get enlarged in the bevel. The tip of the tube can get enlarged in the left arytenoid cartilage. So one gets stuck with the right arytenoid cartilage, just rotated anti-clockwise 90 degrees. This is to show how the size of the endotracheal tube matters. You can see here there's a lot of difference between the size of the endotracheal tube and the diameter of the fiber optic scope. So one of the methods is why you can if possible use a smaller size endotracheal tube, or one can use a smaller size endotracheal tube inside the outer tube. So after passing the fiber optic scope through the glottis into the trachea, the outer tube is then advanced. So so this inner tube just helps to keep the fiber optic cord steady, and once it reaches inside the trachea, the outer tube is advanced and the fiber optic scope along with the inner tube is pulled out. This I have explained. So to summarize, so equipment for fiber optic intubation, one should be ready with a bronchoscope, oropharyngeal airways, nasopharyngeal airways, LMAs, and your alternative methods of securing the airway in case your fiber optic intubation fails. Tillet, Buji, laryngoscope of different base sizes, two suctions, one for the fiber optic, one for the oropharyngeal suction. Different endotracheal tube sizes from 5 to 8. Local anesthetic, resuscitation drugs, jelly, ambu bag, fixation band, cricothyrotomy, tracheostomy sets, oxygen source, and monitoring equipment. So checklist is fiber optic should be sterilized. You should check the movement of the tip. Suction valve should be attached. Light source attached and operational. Connect the bronchoscope to the monitor. Defob the tick of the scope. Focus the eyepiece and the camera of the camera, so there is no pixel drop. Lubricate the scope while railroading the endotracheal tube, and endotracheal tube has to be secured with a tape at the proximal end. Otherwise, it can keep on falling, and your advancement of the fiber optic scope can be difficult. So I'll be now demonstrating two videos. Before that, a little bit about the sterilization. So autoclaving or heating can damage the glass fibers. So typically, cold sterilization with 2% alkaline glyceraldehyde is used. Rinse with filtered water after sterilization, and external surface every time should be inspected for any residual biological matter. It should be cleaned, and it should be tested after each procedure. So I'll be showing two videos now. One is how showing the parts of the fiber optic scope. Another one is we have made in an anesthetized paralyzed patient in an oral fiber optic intubation, and we have taken the consent from the patient. Hello, I will be demonstrating the parts of the flexible fiber optic. This is the body of the fiber optic scope. This is the shaft. In the body, there is an eyepiece. You can see this is the eyepiece on which the camera connector can be connected, and it can be viewed in the camera also. This is the diopter ring in the body. This is to focus. This is the lever which controls the movement of the tip of the fiber optic. If it goes up, the movement is down. This is around 130 degrees. And the upward movement is around 180. This is the Olympus company fiber optic scope that we have. Here is the suction which is connected over here, and the suction is done by pressing this particular port. This is the working channel through which oxygen can be instilled. Also, drugs can be given. Lighting spray as you go technique, we give the drugs. The total length of the fiber optic is around 89 centimeters. The length of the fiber optic shaft is around 60 centimeters. Here you can see, here it is. The outer diameter of this is 5 millimeter. Here you can see this is the working channel, and other the fiber optic cables for illumination. Here is where the light source is connected, and I will also show you how it goes. Now I'll show how the eyepiece is connected to the camera. So by pressing these two buttons, it goes in here. And this is the light source which goes in here. Okay. Now it is well connected. We'll switch on the light source. And one needs to focus both the camera and the fiber optic. I've already focused it here. So you can see. And for the white balance, we need to press the button for the white balance. So that is done. Here I'm using it on the gauze. And this is the mark which should be kept in the front. So let me know the orientation of this. So this is how we use it. The lever should be on the thumb on the left hand, and you can control the movement of the fiber. Now I'll be showing the video for the fiber optic oral intubation. I will demonstrate. So now we are going to demonstrate how fiber optic intubation is being done. Next, patient is anesthetized and oral by the oral approach. This is the rating movement in the non-dominant hand, and the movement of the legal is controlled with the thumb. You can see two thumbs up in here. We have connected this mic source and the camera is over there. So jelly has to be put on the nostril on the fiber optics. You open the mouth. Has to be introduced from the center. And we keep looking at the structures in the camera while we go on. So you can see it's across the base of the tongue. Now there is the epiglottis, it's past the epiglottis. And at my cartilages, we have to center it by movement of the liver and completely rotating the body. So there is the trachea. You can see the tracheal rings here. You have to keep the point in the center where we are going. So once it reaches the carina, you put it over there and the pupils introduced. So you can see the monkey's eye and a slowly withdraw, looking at the carina. These are the tracheal rings of the endocrine. So we connect the plate connected to the socket, see the ETC and garden then it is cut off. So now we are I come to the end of my talk. The possible questions which can be asked in the exam can be how to anesthetize the airway for an awake fiber optic intubation or awake nasotracheal intubation, and you can be asked in the viva the various parts of the fiber optic scope. Thank you so much.
Thank you, Dr. Anupama, for an exhaustive lecture on fiber optic bronchoscopy. And are there any questions?
No, ma'am. There are no questions.
No questions. Okay, I thank Anupama for a lecture and Dr. Raj also. So over to the coordinator for the day, Dr.
Thank you,
Nitin.
ma'am.
Thank you,
Thank
Namita.
you. Thank you so much, ma'am. Thank you, ma'am, and thanks to the speaker for such wonderful presentation. Very elaborate, and I think the videos have really helped the students to understand it in a more practical and clinical way. So thank you so much. We'll move on to the last session of today. And I would like to invite the chairperson for this session. So this session will be chaired by Dr. Alka Gupta. Ma'am is professor at ABVMS and Dr. RML Hospital, New Delhi. And ma'am's area of special interest is neuroanesthesia. We welcome you, ma'am. Alka ma'am, can you switch on your video and the audio?
Hello, you can hear me?
Welcome, ma'am. Yes, yes, we can hear you, ma'am. Welcome, ma'am.
Okay, thank you. First presentation in this session is by Dr. Shikhar. He is a senior resident in our hospital, that is RML Hospital. I welcome Shikhar. Dr. Shikhar, please, you are going to speak about X-rays, please.
Good evening, ma'am. Good evening, ma'am, and good evening, everyone out here. I hope I'm audible to everyone out there.
Yeah, you're audible.
You are
You're
audible.
audible. We can start with your presentation. Yes, we can start.
Okay, sir.
The other presentation, not this, I think.
The next presentation is by Dr. Amrita. She is from SN Medical College, Agra. On elderly, she will speak on
Everyone, my name is
score.
Dr. Shikhar.